A very good afternoon to you all. On behalf of the Postgraduate Institute of Medical Education and Research and the World NCD Federation, I welcome you to this webinar session 11 on COVID-19 and non-communicable diseases. While Professor J.S. Thakur will be joining us in a while, I am connecting you to Professor Anil Bhansali, who is the head of the Department of Endocrinology at PGI Chandigarh, and he would be talking about COVID-19 and diabetes. Connecting you to Professor Bhansali. Slide.
Slides how to move? You will move.
It will move.
Right, that's it.
No. Yes. Thank you, Arpit. Good afternoon, everybody. I am from PGI Chandigarh, Dr. Anil Bhansali, heading the Department of Endocrinology. We are already in the phase 4 of the lockdown, and we are experiencing a second peak because of the consequent relaxation in the phase 4. And diabetes has always been a concern for the patients with COVID-19. So we are going to discuss, as we all know, that India is a diabetes capital of the world. So we constitute something around 6 crores of the people are having a diabetes in this country, and possibly the equal number of patients with the pre-diabetes who are at a very high risk for acquiring the COVID-19. And that's why this has become of a major concern and also of a major interest to all the physicians of this country. One general misconception is that patients with diabetes, are they really predisposed for increased incidence of COVID-19? The answer is no. The patients with diabetes, they are not predisposed for increased incidence of COVID-19, and the last data from China of 1,099 patients, and 7.4% of the patients had a diabetes in this cohort. So meaning by that, the 93% of the patients were non-diabetic who did not have a diabetes. As against to the prevalence of diabetes in China is something around 11%. So it suggests that the patients with diabetes, they are not predisposed for increased incidence of COVID-19. They are not predisposed for increase in incidence of COVID-19, and they have a similar predisposition as non-diabetic. However, they do have a more severe disease, and we see this data that those patients who had a diabetes, 16% had a more severe disease and required ventilator, against the 5.7% of the patients who were not diabetic. The concern again goes higher because majority of diabetics, they do have a hypertension, they do have a cardiovascular disease, and we'll discuss that why this group of patients with the non-communicable diseases, particularly with hypertension and cardiovascular disease, they do have a more severe disease. So what are the clinical evidences for that? That patients with diabetes, they do have a more severe disease. So this is again a data from Wuhan, again from China, and shows that the 3-point map, that is the major adverse pulmonary events, which includes admission to ICU, invasive ventilation, or death. So there was a 59%. You see the hazard ratio of 1.59. So means that 59% of the patients had a higher risk of having these major adverse pulmonary events, particularly those who had diabetes. Even a data from Seattle, the 58% of critically ill patients had diabetes, and similar data are in consonance with the Italy, that 66% of the patients who died had diabetes. So meaning by that, the patients with diabetes, certainly they do have a more severe disease, they do have a more frequent admission for ICU, may require invasive ventilation, and eventually may die as well. There are certain molecular evidences that why diabetics are more predisposed in scenario of a why more severe disease. Because the patients with COVID-19, they do experience a florid cytokine storm, which is comprising of IL-6, TNF-alpha, interleukin-1 beta, and this leads to downregulation of messenger RNA for IRS1, that is an insulin signaling pathway. In addition, the lot of cytokines leads to more release of free fatty acids from adipocytes and thereby producing lipotoxicity, and both these contribute to worsening of insulin resistance in patients who had acquired COVID-19. In addition, I will also talk about ACE2, and my other colleague Dr. Rajesh will also talk about the ACE2 and cardiovascular disease and predisposition for COVID-19. The ACE2 is also expressed on pancreatic islets. They are upregulated during the acute phase, and this, as we all know, that the COVID-19, the entry pathway or the entry portal is basically ACE2, that also facilitates the viral entry into beta cell and consequently damage to the beta cell. This leads to more severe hyperglycemia in patients with COVID-19. The next question comes, we had enough data of controlling diabetes in acute sepsis or in acute critical illness, and we have a final data from a nice sugar data which shows that try to keep a blood glucose between 140 to 180 milligram per deciliter in patients those who are critically ill. Such data for viral infections, they are also there, and hyperglycemia, particularly you have a more increased glucose concentration in alveolar secretion, as the lung is the primary site or the predominant site which is involved by the COVID-19. Pulmonary epithelial cells in vitro have been shown to, if they are exposed to hyperglycemic milieu, and they are more susceptible to other viral infections and replications, and it also dysregulates antiviral immune response and subsequent fatal outcome. So meaning by that, there is a role of controlling blood glucose during acute viral infection. If you go further, what about the anti-diabetic drugs? So you have a lot of anti-diabetic drugs currently available. So plethora of anti-diabetic drugs are available for the management of diabetes. But I think if you ask me in a one word, that what is the choice of among all these drugs, I think the best answer is only insulin. So use insulin in these patients who are having a COVID-19, particularly those who are having a either requiring a ICU support or an oxygen support, and those who are mildly symptomatic, if they are very well on oral hypoglycemic agents and well controlled, it's fine. If they are not controlled, even they can be added with the long-acting insulins, analogs. Otherwise, rest of the people who are sick and severe, having a severe disease, they should receive, rather they must receive only insulin, particularly in a basal bolus form. There are certain drugs of interest which a diabetologist or which a physician should know. What about the thiazolidine and dione and GLP-1? Those who are already on these drugs. However, there is no data to discontinue or to withdraw these drugs, but these drugs have been shown in vitro and as well as in animal model to increase the ACE2 expression. And as I mentioned earlier, that the ACE2 expression facilitates the entry of virus into the pulmonary pneumocytes as well as in the beta cell. So this class of drug, however, no robust data to suggest to discontinue, but theoretically they may be harmful. In addition, the SGLT2 inhibitor should be avoided. The reason for that, they may worsen dehydration and they can lead to euglycemic decay. We also know that the patients with COVID-19 has got a predisposition for a myocardial damage, acute myocardial damage. So even in that situation, one may argue that the SGLT2 inhibitor may be useful, but I think whenever there is an acute myocardial injury, these drugs should be avoided otherwise as well. As far as the DPP4 inhibitors is concerned, they do have some immunomodulatory role, and it has been shown that the Ebola virus disease, there was some, because the DPP4 entry is the Ebola enters through DPP4, that's why the DPP4 inhibitor may play a role. So we thought that even the similar analogy, whether you can use DPP4 or you can continue with the DPP4 inhibitor, may be beneficial. The another drug which has been told by even President Trump as a magic drug or the game-changing drug was the hydroxychloroquine. However, the data which have emerged after the use of this class of drug are disappointing. But hydroxychloroquine, because it is used in, that is also one of the, has been proposed that why the patients with diabetes are having a lesser severe disease, possibly hydroxychloroquine also inhibits the entry of the virus into the pneumocytes. But however, the data are not so robust, It is currently only recommended for as a prophylaxis or chemoprophylaxis for healthcare professionals. In addition, sulfonylureas, yes, particularly elderly people sick, should be omitted. So I think the best answer remains insulin, basal bolus, and those who are moderately or mildly symptomatic, they can be continued with the ongoing drugs, and if required, there are peaks of glucose, then they can be added short or long-acting insulin accordingly. We go further. So this is we had a small publication few days earlier only, the COVID-19, diabetes and ACE2, the conundrum, and what we showed that how this the RAS physiology, and this is how I think Rajesh is going to explain in a better way. So what I want to say that the ACE2 is expressed on pneumocytes, and ACE2 is degraded by angiotensin 2 is degraded by ACE2 to AT17, which is a vasodilator which opposes aldosterone and causes immunomodulation. And what we say that in patients with diabetes, ACE2, there are debatable reports. Some say upregulated, some say downregulated. But certainly those diabetics who are on ACE and ARBs, they have an upregulated ACE2. If you have an upregulated ACE2, then you will have a more facilitated entry of the virus into the cell. So as shown in this diagram is that these are the pneumocytes, and what we have shown in this, the ACE2, it acts as a portal for the SARS-CoV-2. It binds to the receptor, it is internalized and it is degraded. So if you have got a higher ACE2 expression on ACE inhibitor or ARBs, you will definitely have a more entry of virus into pneumocytes and more viral replication. But another thing which is going to happen, if the ACE2 is reduced, then angiotensin 2 is now degraded. So there is an accumulation of angiotensin 2 which leads to more hypertension and hypokalemia in patients with COVID-19. And what has been shown that one clinical and biochemical abnormality which has been shown in COVID-19 patients is the higher incidence of hypertension and hypokalemia, and this is associated with reduced angiotensin 2 degradation because of more ACE2 internalization. So that explains that's why the ACE2 is a double-edged sword in that scenario. If you continue to use, you will have a more upregulation, more entry, but you will have a more angiotensin 2. That's why most of the bodies globally have decided, however the data are not there, but have decided to continue those are ACE and ARBs, but do not start ACE and ARBs in patients who are already treatment naive. This is a word about a chloroquine, how does it act? So it halts the glycosylation of the ACE2R, which has to be glycosylated before the virus enters. And secondly, it also increases the pH, and this pH is responsible. So alkaline pH is responsible for that. So hydroxychloroquine favors that. In addition, it also has got an effect on viral DNA and RNA, and that's why attenuating the cytokine response. So hydroxychloroquine, theoretically, and some data shows that it is likely to have a beneficial effects, but certainly the data are not so robust, and whatever the data which are available, they have not shown the beneficial outcome with the use of chloroquine. You've heard about, because the question which arises in the mind is that why the patients with diabetes, hypertension, they do have a more predisposition, or particularly they do have more mortality, more severe disease. As I mentioned that the reason is that the autopsy data from Italy have very clearly shown that it is not the ARDS which is killing to the patient. It is basically ischemia to the organ and consequently organ dysfunction. And ischemia happens as a result of intravascular thrombosis. So what has been shown in autopsy data, there is an increased enhancement or increased predisposition for intravascular thrombosis. Patients with diabetes, they do have a more predisposition for thrombosis, and again the COVID-19, so it makes a risk. And in addition, diabetes, hypertension, they're already having a vasculopathy. So if the vessel wall is also damaged, if there is a more tendency for thrombosis formation or formation of thrombosis, you will have a definitely more higher risk. Therefore, these three non-communicable diseases, diabetes, hypertension and CVD, because patients with CVD are already having a vasculopathy. On the top of that, the COVID-mediated more intravascular thrombosis will lead to more ischemia and organ dysfunction. And that's why the concurrent use of ACE and inhibitors may also attribute to more severe disease, because majority of diabetics and hypertension are on ACE and ARBs. So this gives an explanation that why the diabetics and hypertensive, they do have a more severe disease, because the pathophysiology of a disease which was believed earlier was an ARDS, in fact which is not, it is a more intravascular thrombosis. So what is going to be my last slide about the post-lockdown scenario? The hospitalization for a non-COVID morbidities is on decline, and it is not because of that these patients are scared to come to the hospital, and consequently it may result in higher mortality. I think that's another worrisome point, because most of the hospitals in the country have focused on COVID, and so the non-COVID patients, they are not coming to the hospital, they are scared. So that's why the morbidities for and mortality for the non-COVID patients may increase during this period. The telemedicine consultation will be preferred than through the physical visits, because and may result in lack of comprehensive evaluation and requires legal endorsement. I think it is also very important whatever prescription you give on telemedicine consultation or a telephone, it requires a legal endorsement, and I think people are working in this direction as well. We'll advise our diabetics to go for self-monitoring of blood glucose and self-monitoring of blood pressure to involve their own care. Availability of medicine and medical results should be smoothly ensured, because what we have faced during few days is that the insulin is not available at many places. Medicines may not be available. So if this is happening in a smart cities or a metro cities, this may happen in a rural area or district headquarters where the medicines may not be available. This should be ensured. And lifestyle modification, the one should get adhere to that. And one can say usually in a lockdown period, usually the weight gain of around 2 to 3 kg, and what we are going to plan to study that what happens to the glycemic control after lockdown is over. And preventive measures, I think we have to learn how to live with corona. So this is going to happen because we are experiencing a second peak. We may continue to experience a third peak or a fourth peak, because the movement, the way in which the movement of the migrant laborers which is happening in our country, and people are still not obeying these common crucial measures. One is wearing of mask, second is frequent sanitization, and third is physical distancing, which the people are not following so aggressively and religiously. This should be inculcated as a part of lifestyle rather than as a part of punishment. So we have to live with the corona, and I think we should start our all OPDs in that way, and we should take care of the patients, and one should not be scared, because these things are going to happen for a long, more than a year plus. So we can't wait for that. So lockdown cannot be continued for months or years. One has to come out and one has to win over the corona. Thank you. Thank you for your patience hearing.
Many thanks to Professor Bhansali for such a beautiful start to this webinar, and also for such an in-depth analysis of COVID-19 and diabetes. While this is your chance to post us your questions through the live chat, and we will be breaking for less than a minute, and we will be back with our next speaker of the day, who is Professor Rajesh Vijayvargiya from the Advanced Cardiac Center, PGI Chandigarh. So we will be back in a very short while. So welcome back, and connecting you straight to Professor Rajesh Vijayvargiya.
Good afternoon, everyone. On the behalf of Department of Cardiology, PGI Chandigarh, I am going to present this webinar on COVID and its cardiovascular management, cardiovascular involvement and the management. If we are going to talk about the COVID and cardiovascular system, we are supposed to cover up, say, hypertension, renin-angiotensin system, and its controversy with the COVID infection, role of statin therapy with the ongoing viral infection, myocardial injury and infarction, and what are the long-term sequelae of a COVID infection to the cardiovascular system. So let me go ahead one by one. Regarding the hypertension and the COVID, it has been found in the epidemiological studies from China, Europe, and Western world that there is an increase in the mortality and mortality along with the COVID-19 infection. Studies from China have shown a hazard ratio for the mortality of 1.7 with hypertension and a hazard ratio of 1.82 with the acute respiratory distress syndrome in case the COVID patient is associated with hypertension. Another study by Zhu et al. Has found a hazard ratio of 3.05 for in-hospital mortality in those who are having active COVID infection. But here I let you know about that there, regarding the mortality, there are lot many confounding variables, and contributing it isolated to the hypertension as a cause of increased mortality is not true. There is unclear pathogenesis between the hypertension and COVID-19. And as Dr. Bansali, my previous speaker, has already mentioned about that, non-communicable diseases like hypertension, diabetes, and cardiovascular disease are commonly and frequently been associated with the COVID infection. And because of these comorbid illnesses, these patients are more prone to have a high morbidity and also the mortality. So if you see the incidence or the prevalence of the hypertension in COVID patient, it's around 15% in one of the study of 199 patients. And as I already mentioned, hypertension and other comorbid conditions are associated with the severe illness, admission to the ICU, more prone to have a mechanical ventilatory support, and also the mortality. A report of Chinese Center for Disease Control, which has analyzed around 72,000 patients, it is found that the hypertensive patient has a 6% fatality rate, while it's a 10.5% for those who do have an associated cardiovascular disease. If you see this particular table, you can find out that non-communicable diseases like hypertension, diabetes, and cardiovascular diseases are very frequently been associated with the infection, and the highest is the hypertension. And regarding the mortality, if you see, those who are hypertensive do have a mortality of around 39%, those with the diabetes 19%, and cardiovascular disease has not 22%. So these comorbid illness like non-communicable hypertension, diabetes, and cardiovascular diseases are associated with increased mortality in those with COVID infection. Let's have a look on what's the pathogenesis of COVID infection and its interaction with the AC inhibitor. Dr. Bansali has already mentioned about the various pathway which has been associated, and how does this impact the course of the COVID infection. Just to briefly comment about the COVID virus do have a protein spike which do get attached to ACE2 receptor. And while in case we talk about various antihypertensive drugs like AC inhibitor and ARB, they do get attached with the AC1 receptor. So there is a different pathway for the two, and there is no direct association between the AC or ARB inhibitor and pathogenesis or severity of the COVID infection. And because of that, as I already mentioned, that AC2 receptor are the one which are mainly there in the lung. Partially, it is also there in the heart, and then as the virus do attach to the AC2 inhibitor, there is no relation between the AC1 receptor, which has been associated with the effect of AC and ARB antihypertensive drugs. So, does the COVID infected patient need to change from these antihypertensive, which are very frequently and routinely being given to control the blood pressure, especially in those with cardiovascular diseases and diabetes? There is no need, and there is a need to have a close monitoring of this patient in case this has to be switched over to another antihypertensive drug. Otherwise, also the RAS inhibitor, which include AC and ARB, has the beneficial effect in those who are suffering from, say, renal disease, diabetes, hypertension, and cardiovascular disease. Most of the international society like American College of Cardiology, American Heart Association, and European Society of Cardiology has recommended not to discontinue these antihypertensive drugs in COVID patients. They should be continued until and unless there is contraindication for some other reasons. Regarding the role of statin, does it have any role in those patients who do an acute COVID infection? There is no role. There are some observational study which has shown that possibly there is decrease in the ICU stay and improvement in the ICU stay following high dose of statin therapy. One of the randomized control trial by Marquis et al. Has shown that it reduces the mortality in those associated with ventilatory associated pneumonia. While the another randomized control trial has not shown so favorable result with the simvastatin in 60 milligram doses. So, regarding the statin, it has to be continued and adhered to the statin therapy in patients who do have a clinically atherosclerotic cardiovascular disease, diabetes, or those who are already taking the statin therapy should continue. Otherwise, those who are not on statin therapy, there is no rationale or no recommendation to start it in COVID infected patient. Regarding the progression of acute disease and cardiovascular manifestation, stage 1 is the early infection where the patient may be asymptomatic, there is no cardiovascular manifestation as such. Stage 2 is the one when you do have mild symptom and mainly the symptoms are related to the pulmonary infection or pulmonary system. And stage 3 is the one where there is the hyperinflation and then cardiovascular system gets involved into. So regarding the myocardial injury in COVID infection, patient with risk factor for cardiovascular disease, old or having the old coronary artery disease are at risk for developing acute coronary syndrome during the viral infection. And probably the severe increase in the myocardial demand, which is there with the active infection, increased sympathomimetic drive, result into myocardial injury and infarction. So this is either there is an increase in the demand which is related to myocardial injury, or it's the inflammation because you do have the cytokine storm and which result into generalized inflammation, vascular system inflammation, and which result into atherosclerotic plaque instability and rupture leading to acute coronary syndrome. A direct invasion of the virus into the myocardial system can also result into its manifestation like myocarditis. So this is the line diagram about the viral infection and its cardiac manifestation, which include increase in the oxygen demand because of the ongoing infection, plaque instability secondary to inflammation, and then there is a myocardial depression, which is secondary to say acute coronary syndrome or myocarditis. What are the manifestation in the heart? Heart is more prone to have arrhythmic complication like ventricular tachyarrhythmia and sudden cardiac death. Regarding how does the biomarker for the myocardial injury impact the outcome, there are two studies from Wuhan which has shown that around 19 to 27% of the patients do have increased troponin level, and it is not essential that those with the myocardial injury only do have a raised troponin level. It can be a marker of generalized inflammation, and those who are associated with positive troponin level do have very high mortality to the tune of more than 50%. So, as I already mentioned, troponin level which are elevated have a worse outcome, and it is closely associated with the high level of C-reactive protein and pro-BNP level. A progressive increase in troponin and also pro-BNP level is associated with the deterioration and more of mortality in COVID-infected patients. So this is the line diagram very clearly depicting about the cardiovascular disease and the mortality. If you see the lowermost, those without cardiovascular disease, and normal troponin level has the least mortality compared to those who do have a cardiovascular disease and elevated troponin level. So this is again a marker of generalized inflammation, vascular inflammation in the COVID infected patient. Something about the percutaneous coronary intervention in those who are having this ST elevation myocardial infarction, whether it is COVID positive or negative. Ideally, it's the primary PCI which has to be done, but in case it is not done because of the delayed presentation or patient is out of the window period of 90 minutes, thrombolysis can be an alternative. Post thrombolysis, those patients who are hemodynamically unstable or ongoing angina or ischemia is there should be subjected for rescue angioplasty. Regarding the long-term sequelae, cardiovascular sequelae of the COVID infection, as I already mentioned, with the acute phase, you can have unstable angina, acute coronary syndrome because of plaque, instability, and rupture. Myocarditis secondary to myocardial involvement of the COVID infection. And months later, because of sequelae of the viral infection to the heart, one can have a sequence of coronary artery disease, one can have a long-standing myocarditis, and that has to be appropriately managed. Thanks for the kind attention.
Well, many thanks to Professor Rajesh for such a deep insight into cardiovascular diseases and COVID-19. And while this is again your chance to post us your questions through the live chat, we will be breaking for a very short while and we'll be back with the next speaker of the day, who is none other than Professor Dheeraj Khurana from the Department of Neurology, PGI Chandigarh. So we'll be back in a very short while. So welcome back and connecting you to Professor Dheeraj Khurana, who is a professor in the Department of Neurology at PGI Chandigarh, and he would be talking about stroke, a priority during the COVID-19 pandemic.
Good afternoon, everyone. And just like you've been listening to my colleagues, the impact of this pandemic, which has taken a big toll on the world population, and major disorders, especially those involving cardiovascular diseases, diabetes, and stroke. Now, these, remember, are one of the biggest killers, anyways. And a major concern during this pandemic has been not primarily how to manage them, but primarily because of the fear of patients. We have now been noticing less admissions in the last few weeks, in the last few months, and that's one of the things that I would be referring to. So looking at the stroke due to post-COVID-19, well, a number of stray reports emerged initially, which kind of triggered the fear that stroke may actually be a manifestation of COVID-19, and the causes were thrombosis, and this triggered an alarm, thinking that maybe all strokes which are coming may be due to COVID-19. But later on, it was determined that only the severe patients may actually present with a stroke. But the story doesn't end there. Most importantly, what's the pathogenesis? So it's been believed that the reason why strokes may happen is due to either the direct invasion of the virus, leading on to increased reactive oxygen species, and the second, systemic inflammation, which also activates NOx2 and increased reactive species, leading on to a hypercoagulable state, the cytokine storm, as was referred to in the previous lectures. Interestingly, the coagulopathy, which now is being determined as more and more knowledge and information getting evolved, we are finding that it is likely linked to the cytokine storm, which we just referred to, or it could be DIC due to multi-organ failure, which may happen as a result of complications of the virus rather than a direct viral effect. And importantly, the clots in the venous circulation have been found to be more common. And this is basically reports coming recently from the Italian pandemic. And patients have been having greater incidence of DVT and pulmonary embolism. Recently, a paper which is of huge interest was the largest autopsy series of 19 patients, which was reported from Germany, another major country which was affected by the pandemic. And what this revealed is quite insightful, that a number of patients who had which was not suspected during their life was found that they were having deep venous thrombosis, and it was leading on to the pulmonary embolism, which led on to death. So DVT seems to be, the venous thrombosis seems to be more commonly happening in COVID-19 infections, and strokes are also happening, but as the initial fear was there, they're not happening in the milder patients, but may present in the severer part of the viral infection and on the later part of the infection. So publications like these, which was also from China, where young patients with large vessel artery occlusions were shown to be manifestations of COVID-19. However, this change, the major change which needs to be highlighted, which is a big concern amongst the stroke treating community of our country, is the fact that patients have markedly reduced as far as their presentation to the hospitals is concerned, and stroke care in the time of COVID-19 has very significantly changed due to these facts. If we look at the data all over the world, there is a marked reduction in the admission rates of strokes, and it is believed in the US around 25 to 35% of admissions. They have come down by 25 to 35% for both heart attacks and strokes. And what major change has been effected and what is being recommended across the world is that neurologists, we are not recommending not to see a stroke, but all strokes need to be seen. On the contrary, we are in fact reaching out to the public and we are telling them that stroke is still an emergency and they need to reach out to the hospital to get themselves treated rather than being fearful of getting an infection, because stroke carries a large morbidity and disability along with it, and that is going to worsen major health problems of the whole society. Neurologists have been recommended to wear at least use level 2 protection or PPE depending upon the level of the risk, and usually level 2 is sufficient for patients who are not COVID or unsuspected COVIDs. Another important change which is being recommended, since strokes require a specific pathway, is what we call as stroke green pathway, which indicates nothing but a dedicated pathway, a dedicated CD scanner or a scanning machine if an MRI is being used, and these should be kept separate for stroke patients, since these may not be COVID patients and the risk of combining them with a COVID facility may put these patients at further risk. Second important thing is the protected stroke code, which I'll talk of. So the major challenges which have been faced by stroke teams across the world and in India is primarily change in our protocols. We don't seamlessly take the patients into the imaging, and there has been change in the diagnostic test protocols. What is being recommended is that patients should undergo a COVID testing even if they are not suspected as per a checklist, and because of the information that we are receiving that most of these patients in severe forms of COVID may have a stroke. So second part, like I said, neuroimaging, we should stick on to early neuroimaging, but a CT scan alone is sufficient, since MRIs should be avoided because getting an MRI machine sanitized after doing a possible suspected patient is not that easy. Important challenge which is also faced by most stroke teams is Since you may not be able to get a detailed neurological evaluation as well as a history from a patient who has a stroke due to the delirium or the respiratory distress, it may not be possible to really suspect COVID, and usually these patients may not even have attendant coming along with them. So it's very important to keep a high degree of suspicion even if there is no relevant history forthcoming in these patients. What about the present stroke scenario in India? We've had a lot of communications with various stroke centers of the country. We believe, initially we thought there is a 80% reduction in stroke admissions looking at the initial data. Our stroke load at PGI markedly reduced all the thrombolysis rates. They reduced by around 50%. And since then, we have been able to collate data across the country. And this recent publication, which has come in the New York Academy of Sciences, it shows marked reduction in various stroke centers across the country, which is reported by the stroke teams in these sites. And what we see is almost as 50 to 60% reduction in total strokes. The thrombolysis rates have gone down by 60%, and thrombectomies have gone down by 40%. Now, why thrombectomies are lesser affected? I'll tell you the reason. Even we have been doing quite frequent thrombectomies relatively, because most patients tend to come at a later window period. By the time thrombolysis window periods are elapsed, and they may be candidates for thrombectomies. Major challenges which are still being faced are, and will be faced maybe in the future, are overburdened emergency rooms. Right now the lockdowns are there, so our emergency rooms are not that overburdened, but we are going to face these challenges, and we need to be prepared for these. Screening difficulties are going to be there. Now, resource limitations in terms of PPE supplies, which was initially a big problem, but I think it is now getting settled across the country. And importantly, what kind of best care should we give to a stroke patient who may be COVID suspect or positive? So one thing is, like I said, even during a pandemic, the message needs to go out to the public that strokes and coronary events are still an emergency. They should be treated, and physicians and stroke teams should be ready to take on a stroke. Even worldwide, major protocol changes happened. China reported reduced functioning. Worldwide countries with highly efficient stroke systems, you can imagine, they reported a big change because patients had no idea whether to attend a hospital or go stay home, and they didn't know where to go for treatment. The same thing must have happened in India because we had different designations for hospitals. There were COVID designated hospitals, and then there were non-COVID designated hospitals. So patients would be confused where to go. But whatever the case, we need to tell them to reach to their nearest stroke ready hospital or a stroke treating hospital. And what is more important is the teams at the stroke hospital, whether COVID hospital or a non-COVID, should be prepared to take these. So what is recommended internationally by this publication from Calgary is the protected code stroke, which refers to nothing but an extra precautions by the team to get themselves protected. So what they recommend is, for all patients, they recommend a PPE. And like I said, along with either if a PPV, especially if there's a COVID highly suspect patient, or a level 2 protection, which includes eye shield, a mask, and gloves, minimal. And importantly, the mask should be put even on the patient while the patient is shifted for imaging and then back from imaging to the emergency room. The patient should always be wearing a mask till the time you're not sure of the status. Green pathway, like I just mentioned. So what all we have been able to achieve, a stroke green pathway, which is a separate pathway for stroke patients, should be established. We were able to establish that with coordination with our radiology teams, and we have luckily we have a separate building for COVID, and a non-COVID building is separate, so we could keep these CTs separate. COVID-19 suspect and positive patients, they are sent to a pre-designated facility, so that's again achievable in COVID hospitals. Pre-notification to CT facility, we are able to do that. This is important so that the CT staff is ready to take the patient. CT chest should be done simultaneously. Now that's a very important step that has been taken up by all stroke teams, since you cannot figure out whether the patient is COVID positive or negative. A high resolution CT scan should be done along with the brain CT to get some idea about the COVID infection. MRI should be used sparingly. Now that's one major precaution. So total patients that we have treated in the last around 2 months, is 30 patients, out of which most of them were ischemic, and their time to reach PGI was quite delayed, as you can see from the time they reached here. We could manage around to do 3 thrombolysis. One we managed we have a hub and spoke model with a community hospital in Chandigarh, and we were able to guide a thrombolysis in the other hospital. And in fact, we had more patients undergoing mechanical thrombectomy, like I mentioned, because most of the patients, they reach out of the window period. COVID testing was done only for 2 patients, but now is getting changed, and now we can do it for all our patients, because initially all patients reaching the emergency were not offered a COVID test, and these COVID tests, they were negative in both these patients. So another thing which we have activated is a StrokeNet, which is a hub and spoke model using a mobile application by which we can connect teams within the hub, which is PGI, and the spoke. The spoke is primarily the community hospital. The major aim is to reduce communication, reduce contact between the various members of the team, and this is being tested these days, and we plan to even use this for COVID teams who can communicate within the hospital as well as between hub and spokes. Another thing which needs to be remembered, if the patient reaches a COVID negative or a non-COVID hospital, this is important because of the different designations. It's important that if the COVID non-COVID designate hospital has a team, they should be able to manage, or they should refer to a COVID-19 designated hospital which has a stroke team, and they should liaison with the nearest available stroke team if they do not have a COVID-19 designated hospital. However, priority should remain that the necessary treatment should be provided in the eligible window period. We have come up with a consensus statement by the Indian Stroke Association of recommendations for management of acute stroke during the COVID-19. Important changes which have happened across the world are telemedicine, which is being promoted, and a lot of rules have been changed. Even in the US, non-HIPAA compliant, as they call, which is a Privacy Act as they were using, they have waived off for the time being potential penalties for using platforms like FaceTime and Skype, which are not allowed, and telemedicine guidelines, which have come up very recently, right after the pandemic, COVID pandemic, which is a welcome thing in India, and we now have legal sanction to use various telemedicine platforms, and these are being developed in India. However, challenges in India with telemedicine are patient acceptability, outreach is not possible, we may have challenges with internet connectivity, and acute emergencies must still not be properly handled because we don't have the right platforms. So what this achieves, telemedicine and telestroke achieves virtual teaming up, which can reduce effectively the contact between members of the team and bring about virtual distancing. So that's another of the medical application that we created earlier prior to the pandemic, which was to provide early post-stroke care to our patients. But I won't go in detail for this, but this has been tested in a clinical trial and has been found to be very effective. So in the last, what I would say the best plan for strokes to be treated in the current times are, first of all, to allay anxiety of the public, inform them about facts that strokes need to be treated and they should not be staying back at home. They should reach out to a hospital. Local guidelines have to be established. If national guidelines are available, local guidelines within the hospital by the stroke teams need to be established so that their team is ready. Do not wait for the COVID test results to treat a patient. That's very important because you will lose the window for treatment for stroke patients. Use telemedicine in triage or for treating patients across different hospitals. This should make things faster, and designate roles and teams where specific roles need to be given to different members of the team, and one needs to get practice to utilize these plans. Importantly, before I end, I would like to acknowledge our nurses who have been in the front line, have been playing an important role. These are our stroke nurses who have been managing all during this time, the stroke patients reaching the emergency. Thank you.
Well, many thanks to Professor Khurana for such a wonderful discussion on stroke and COVID-19. This is your last chance to post us your questions through the live chat, and we will be back with a panel discussion in a very short while. So welcome back, and we have an esteemed panel of experts today. Professor Bansali from endocrinology, Professor Rajesh from cardiology, and Professor Dheeraj Khurana from neurology. Well, thank you so much, sir, for such a deep insight into non-communicable diseases and COVID-19. And starting with Professor Bansali, sir, you had told in detail about hydroxychloroquine, and you had also told that in many of the trials it has failed. But still, the use of hydroxychloroquine as a drug for prophylaxis, especially to the healthcare workers, is being continued. So, do you have something to say about it?
As I mentioned that the hydroxychloroquine has been used earlier also and has also been used during this trial of the COVID-19 pandemic. But the data which has emerged, whether it has really affected or had any impact on the outcome of the COVID-19, has not been shown. It was believed that the drug has got a possible mechanism to deal and to contain the coronavirus into the lymphocytes, but has not been proven to be that. However, the data only for a chemoprophylaxis for healthcare professionals which are available and shows that possibly it has halted the occurrence of the COVID-19 in as a chemoprophylaxis. So that is the only data which supports to be used in that. Otherwise, for continuing or as a management strategy in patients with COVID-19, I think it has not still proven.
So the take-home message is we have a possible data saying that as a chemoprophylactic drug,
For
it
health-
may be or it might be effective,
For
but
healthcare
not
workers-
definitely not for the management.
For healthcare workers, it's okay, but for otherwise, for that, it is not.
Yeah, Professor.
I hereby want to add something about hydroxychloroquine and cardiac toxicity. For a routine chemoprophylaxis, one should be careful that this particular drugs do have an increased QT interval and risk for proarrhythmia and ventricular tachycardia, especially those who are suffering from underlying heart disease like coronary artery disease or LV systolic dysfunction. So these subset of patient or these individual, healthy individual who do have say increase in the QT interval on the ECG or underlying cardiovascular disease should have the consultation with the physician before starting these chemoprophylaxis, because there is a risk to have a ventricular tachyarrhythmia in them following this particular drug. So there is a side effect of this drug as well, and those who do have a cardiovascular disease should be careful in taking this prophylaxis.
So this is a very important message coming up that those with some cardiac concerns should be very careful before taking this.
Particularly QT interval is
Yeah, because it lengthens the QT interval.
And I think addition of azithromycin, it adds on to the QTC
Yeah.
prolongation. And that
So
will
there
be-
has been a case report probably where one of
Yes.
the doctors probably
Yes.
had we have lost the life of a doctor because of this. Yeah. Okay. Thank you, sir, for taking this. Shifting on to Professor Khurana, you had talked in detail about a paper which has mentioned that there is some kind of thromboembolism, which is probably the reason for COVID-related deaths. So, are we foreseeing an era where there will be overflooding of stroke and cardiovascular complaints in post-COVID era? Are we foreseeing that?
I really don't think so. In fact, like I mentioned, the number of stroke admissions have come down. Major reason being it's not a reduction in the incidence of stroke. The reduction is because of the fear of patients not reaching the hospital. So as far as COVID and its link to stroke and cardiovascular disorders, I don't think so, because for one reason in India, what has been reported till now is we are seeing milder infections. The majority of the patients are milder, and likely we don't have still data of how many patients reported with COVID had a stroke. 2 patients of I know in All India Institute, they were hemorrhages, so you cannot say that it was thrombosis. There were 2 ICH patients which I am aware of, which exposed the team in AIMS. We've not had that kind of a scenario till now, but it may be possible if you start seeing more severe COVIDs, then yes, strokes and cardiovascular disease may become more common with severe COVID. But as far as the milders are concerned, till now the data says that mild COVID infections may not be associated, and that fits in with the pathophysiology. Like we said, the cytokine storm, the thrombosis, the DIC, They are all linked, and that happens with severe COVID only.
So, do we understand that the patients who are already at risk, which we call as at risk, having some kind of an NCD, they would be having severe implications of COVID-19? Do you understand it this way as well?
In a way, one way to avoid any kind of further risk is don't stop your medications and do not stop your risk mitigation strategies. So patients who are already at risk with diabetes, all the experts sitting here, their fields are one of the risks of stroke. So they should take care of sugars. We already know diabetic patients are at greater risk of having COVID. So they're linked. So if you take care of your diabetes, you won't have a severe COVID and you won't have a stroke. So take care of your risk factors. That's the biggest message that needs to go across to even primary health centers, primary care physicians, and let people take care of their primary risk factors and take exercise as we normally tell them to do.
Well, thank you
One
so
more
much.
point
Yeah, please.
I would like to add it here is that, like the autopsy data from Italy, they have also shown that
Yes.
there is a differential predilection for vascular thrombosis, particularly for pulmonary vasculature. So cerebral vasculature may not have a similar predisposition for thrombosis as pulmonary vasculature. So that also shows that the stroke may not be related directly with the COVID-19. So more finding a pulmonary vasculature and then finally having an ARDS. So that may be a consider. So the differential selectivity or a predisposition for the vasculature may also be contributory for what type of vascular thrombosis you have and eventually organ dysfunction.
Well, sir, many thanks for clarifying this. And coming next to Professor Rajesh, sir, as you know, I mean, there are a lot of cardiovascular patients, and almost all are on some kind of statins or blood thinners, aspirin or something else, and also maybe some kind of an antihypertensive as well. So, is there some specific message for them as far as COVID is concerned?
I would like to say that as you have already seen about my presentation, these hypertension, diabetes, and coronary artery disease, all these three diseases are commonly been associated with the COVID infected patient and are associated with increase in the morbidity and mortality. So all these three diseases should be appropriately controlled. What sort of medication and drugs one is taking should continue. Regarding the blood pressure, it should be well controlled. No shifting of the drug to something else until and unless you do an as a teleconsultation with the treating physician about the control of the blood pressure. One has to continue with the statin and antiplatelet drugs as well. Um, Antiplatelet drugs do help in prevention of acute coronary syndrome, plaque rupture, and its manifestation, which has been demonstrated very well with the COVID infection. So, what sort of medication you are taking, take it and optimize the management with the consultation of your treating physician. That's the important message which should have been followed during this ongoing pandemic.
Well, thank you, sir. Taking the talk a bit ahead, the cardiology department or the advanced cardiology center at PGI, we have been dealing with so many cardiac emergencies, and even same goes for stroke. So there are so many emergencies reporting up. For some, there would be a window period of getting the patient tested, but for others, there would definitely be no window period. So, what is the PGI protocol of managing such patients?
So, as cardiovascular manifestation is very common in COVID infected patient, and one of the report has shown that 40% of acute MI patient doesn't have a significant coronary stenosis during coronary angiography. Our protocol is to give the optimal medical treatment when reporting the emergency, have the COVID test done, and then to go ahead for the invasive management. But in case a patient who do need a primary PCI and has reported well in time at PGI, ideally should be subjected for primary percutaneous coronary intervention instead of thrombolysis.
So do you wait for a COVID-19 test report available, or do you go straight away for the procedure if it is demanding?
So recently we do have a rapid test whose result do come within 2 hours or so. So that's going to
Gene
have
expert.
gene expert. So that's to have to expedite the invasive strategy in those patients who are unstable, ongoing angina, and these patients can be taken on table to go ahead for invasive strategy. And rest of the patient has to be continued on the optimal medical treatment. until and unless there is a hemodynamic deterioration or there are indication to take them for the emergency intervention. In that condition, they are supposed to be taken with all the protective preparation which has to be taken and recommended by PGI.
Thank you.
I could add on to this fact of our patients who underwent thrombectomy. The procedure is quite similar to the cath lab. They were taking, like I mentioned, we had more thrombectomies done than thrombolysis. So the thrombectomy team, they did it. They did all the tests without prior COVID testing, but they used all protective equipment. So although what I have got a feedback from our interventionists is that performing and cath with PPE is very difficult because of the fine movements required, but they have quite an adequate protective gear which is normally also used for intervention.
Yes.
Was it thrombus was different in these? How many were COVID positive?
There were none was COVID. So
None.
the thrombus was same. In fact,
So what I was presuming
Yes.
that they might be having some different characteristic of a thrombus.
that's
Those
exactly what they are.
Those were concurrently having a COVID-19.
We couldn't
So you
find.
might find a more friable clot or more friable
Exactly.
thrombus as
So we didn't find.
Well, many thanks to you for taking this. And Professor Khurana, coming back to you, as among our viewers, we have many healthcare professionals and we are being connected to many health workers at PHCs, CSCs, some district hospitals. So can you explain more about the efforts of teaming up and the hub and the spoke model which you had talked about?
Sure, that I think is the priority right now, to set up hub and spoke networks if it is possible. So for that, someone has to take a lead in a comprehensive stroke center. And a comprehensive stroke centers like PGI, where you have a full-fledged stroke team which offers all kinds of stroke treatments ranging from thrombolysis to intervention and then followed by rehabilitation. So we have the complete cycle being offered. So centers like those can usually feed the spokes, which can typically be community hospitals, and these community hospitals can at least either refer patients, or if they have the capability, they should start the treatment of thrombolysis in their hospital by having an active communication link, either through telemedicine or whatever, or simply communicating. Previously, there have been data on WhatsApp communication links between hub and spokes from Himachal, which have been reported. And we initially started our communication with our community hospital in Chandigarh through a WhatsApp, and later on progressed on to the app which I showed up. So these really help in not only having improving your coverage for stroke treatments, and more people can be treated. They can also help in transferring the patients from the spoke to the hub by using the model of either drip and ship, and even then in the comprehensive stroke centers, you can even treat these patients who may need thrombectomy, which may not be available in a comprehensive stroke center.
And can you explain something about the MAPS application which you had talked about?
Yeah, so MAPS application, I didn't talk in detail about it because of limitation of time. So the MAPS application was an application which we developed, which is a mobile application for post-stroke care strategy. It was part of a study which we conducted as part of a thesis student of mine. And we were able to show by a randomized clinical trial that patients who used the mobile application had a lower incidence of post-stroke complications. Now, relevant to the current scenario, we are planning to offer it to the general public. It is still not available in the App Store. It's called the Stroke Home Care application. Importantly, there were two reasons: because we were planning to push it into a clinical trial across the country, which has already been sanctioned by ICMR. So it was for limited distribution. But now is the need of the hour, and we will start giving it on a case-to-case basis for patients who require post-stroke care, or in fact can be utilized for any bedridden patient, since the complications are common for bedridden stroke patients or other bedridden patients due to any other reason. And since it has been not endorsed, but at least validated by a clinical trial, and we've already been, it has been presented at a number of international forums, and it received a lot of appreciation in terms of various awards which it got. So we think that this should work even on a general usage beyond a clinical trial.
Well, thank you, Professor Khurana. And now we'll be taking some specific questions by our viewers. And there is a question whether Retiplase can be used in stroke management with COVID-19.
That's a very interesting and a very good question. Tenecteplase, as most of you might be aware, has been approved by the guidelines of stroke treatment. So let me tell you, Tenecteplase worldwide is also coming up to be a very effective agent. A host of clinical trials have proven its efficacy. The advantage of Tenecteplase is it's a single shot dose rather than a full infusion for 1 hour, which you give with RTPA or Alteplase. But Tenecteplase needs to be used. The dose which has been approved in India till now is 0.2. Unfortunately, that's not the dose being tested in the rest of the world. The dose is 0.25 with a maximum of 25. So, although it is not officially recommended, but if you have to use it, it has to be the international dose. Likely because initial experience with this dose was not very good, at least in our center. So we've been kind of using mostly Actalize or RTPA, and TNK will be a very good alternative in the coming times. A lot of data which is coming up is very encouraging, but no Retiplase. Sorry, Retiplase should not be used because there have been no clinical trial, and in early clinical trials it was not found to be effective. It is useful likely in coronary artery disease or MIs, but not so in stroke. So please do not use Retiplase. Tenecteplase, if you want to use, you can use the international dose, and Actalize is anyways there. RTP is available.
Well, many thanks to you, sir. And there is a next question coming all the way from Bangladesh, and it is
Ivermectin and doxycycline. Yes.
yeah, ivermectin and
So yes, this yesterday only appeared at the data from Bangladesh. However, it is a very limited data, and as we all know that the COVID-19 does not have any specific treatment so far. Only management has been supportive. People are using different varying combinations of the different antiviral, antiretroviral, antibiotics also, doxycycline and this. But I think again, one can try, it's all hit and trial in that way. But one will not say that these are part and parcel of the treatment strategies for the COVID-19. So, like a data, like I mentioned earlier, even a data with azithromycin and hydroxychloroquine that has also appeared. So, we don't know any specific treatment for a disease. If someone claims and it is already published data, if one tries, it's okay, but may not rely on that, patient will really improve of it, or it will really have an impact on outcome.
well, many thanks to you, sir, again. And there is one more question on low molecular weight heparin dose.
So those individual asymptomatic patient who are on the dual antiplatelet therapy, in case they are asymptomatic, there is no need to put them on low molecular weight heparin until and unless they do have a presentation like acute coronary syndrome, acute myocardial infarction, or they are seriously ill and immobile requiring thromboprophylaxis. So these are the patients that they are bedridden, and then you have to prevent the deep vein thrombosis and pulmonary embolism. There is an indication for low molecular weight heparin.
Well, many thanks to you. And with this,
For
we
the LMWH, I need to add for the stroke was that's a very important fact. A lot of people do ask about giving heparin and anticoagulation, considering the pathophysiology of COVID. So we are not recommending it regularly. That should not be given because in any case, heparin has never been found to be useful in stroke for the treatment of stroke. But yes, DVD prophylaxis, all strokes who are bedridden, we give only the prophylactic dose of either LMWH of 40 milligrams of Clexane or the other we give unfractionated heparin of 5,000 units twice a day. Only this therapeutically we should not give heparin for the treatment of stroke even in COVID-19.
So the take-home message is that it is recommended only as a DBT prophylactic.
It is not for a treatment.
For stroke and for MI, yes, like Rajesh mentioned.
Otherwise, they do have more predisposition for a thrombosis.
Yeah.
So it should be.
Many thanks to the panel of experts for the day. Professor Bhansali from endocrinology, Professor Rajesh from cardiology, and Professor Khurana from neurology. And many thanks to the viewers of the day. And you can keep calling us on the PGI helpline number, which is 0172 2755 This is the PGI coronavirus helpline number, and the helpline experts will also connect you to the relevant experts in PGI and try to solve your future queries.
And we have a stroke helpline if they want to call on that. Mostly it's for acute stroke patients. That's available on our website also.
So you can very well visit the PGI website, that is pgimer.edu.in, for the stroke helpline and other helplines as well. And with this we have come to an end, and I want to thank each one of you for connecting to us, taking out times and posing your questions. Thank you so much. We'll see you back with a new topic on a new day. Until then, goodbye.
Thank you, Abid. Thank you.